Hello, welcome to the Calhoun County Medical Control Authority Medical First Responder and Basic EMT Epinephrine Intramuscular Injection Training. My name is Clark Imus and I will serve as your instructor for this online course. Let's go ahead and get our class underway. We have a few objectives that we'll discuss as we go through our presentation. First will be to demonstrate how to draw up epinephrine from a vial and how to administer it via IM injection using the Calhoun County Medical Control Authority EPI kit. We'll also discuss, given a scenario, how to correctly identify a patient that should receive epinephrine via IM injection. And finally, you'll complete a practical training to administer or simulate epinephrine, in this case sodium chloride, to a simulated patient. Let's go ahead and continue. There are some relevant protocols that we need to make sure that we're aware of. These include 1.6, which is the anaphylaxis and allergic reaction protocol, 3.3, which is our respiratory distress protocol, 4.5, which is our pediatric respiratory distress protocol, 1.6a, which is the medical first responder and basic EMT epinephrine study addendum, and then 8.40, which is the Maybe's medication content kit procedure along with the exchange procedure. Let's get into the topic of anaphylaxis. Anaphylaxis, by definition, is a sudden, severe allergic reaction that can result in death within minutes. Onset, it can occur within seconds or minutes with an exposure to an allergen. Distinguishing mild from moderate allergic reactions by respiratory compromise, angioedema, and/or hypotension can provide you with a significant indication of when to administer IM injection epinephrine. If we look at the specific signs and symptoms, knowing that these can vary from patient to patient, we can see a pretty common theme. Symptoms include hives and swelling, itching, flushing and cyanosis, nausea, vomiting, abdominal cramping, diarrhea, anxiety, angioedema, laryngoedema, laryngospasm, bronchospasm, shortness of breath, wheezing or stridor, tachycardia, and hypotension. Let's dive into this a little bit further to do an additional review for anaphylaxis. When we think about our anaphylaxis review, we must recognize what are the common onsets of symptoms associated with an allergic reaction. These include hives or urticaria. Here you can see these wheel-like discs where slightly raised areas of the skin, and generally you'll find these areas of hives to initiate within areas that are warmer within the body. This includes areas like the core chest, armpits, groin, neck, and back. We can also see things like angioedema. These include swelling of the area beneath the skin, similar to that of urticaria, but affecting deeper layers of tissue. It also can be seen in areas such as the hands, neck, and tongue. Here in this image, you can see a pediatric patient with edema to his face, including his eyes and lips. We are familiar with the use of epinephrine and epinephrine's effects. We must recognize that epi is a primary drug for severe symptomatic reaction or anaphylaxis. We know that the drug itself is a sympathetic agonist, meaning that it stimulates the sympathetic nervous system by causing an effect. We see this demonstrated through an increase in heart rate, increase in contractility or force of contraction of the heart, vasoconstriction to pull blood from the peripheral vessels back to the core of the body. We also see that it can begin to reverse bronchospasms by relaxing the smooth muscles of the airway. It reverses capillary permeability, helping maintain fluid inside the vascular system rather than traveling to the tissue, and we know that it's very effective and acts within minutes. Now the effects of epinephrine, when we look at the pharmacokinetics, our onset is approximately 3 to 5 minutes when administered intramuscular. It remains in the body for about 1 to 4 hours, and its best effects are administered intramuscular into the vastus lateralis or the lateral thigh. Now, there are some side effects that go along with the administration of epinephrine. This is going to vary from patient to patient, but oftentimes will include tremors, vomiting, chills, tachycardia, anxiety, palpitations, nausea, angina or chest pain, and hypertension. Our epinephrine indications are also important. For adults, we're looking for signs of anaphylaxis, which include things like hypotension and/or severe respiratory distress or angioedema. For asthma or our COPD patients, we may see things with wheezing with impending respiratory failure and/or they're unable to tolerate a standardized nebulized therapy. Now our indications are going to be a little bit different when we're dealing for pediatrics. For pediatrics, we're dealing with children that are less than 10 kilograms or 20 pounds. For this, we should be contacting medical control prior to our administration. Our indications for epi for pediatrics include, again, anaphylaxis with demonstration of hypotension, severe respiratory distress and/or angioedema, and then bronchospasms or wheezing. This includes severe respiratory distress and failure. Not only must we know when to give it, but we must know when to withhold it. There are truly no contraindications or absolute contraindications for the administration of epinephrine. It could be that someone has a potential known hypersensitivity, but more likely than not, that won't be the case. We also know that one of the contraindications will be for children who are less than 10 kilograms or 20 pounds. For that, we should be contacting medical control prior to the administration of the drug. When it comes down to our administration of epi or epi dosing, we should be utilizing our B's dosing cards for epi administration. Here you can see that it identifies the 5 rights for administration of a medication, including right patient, right medication, right dose, right route, and right documentation. You can see here that first, this is not to scale, but our adult dosing is going to be 0.3 milliliters if they're greater than that of 60 pounds. For pediatric patients, you're going to see 0.15 milliliters, or half of our adult dose for those that are less than 60 pounds. You can see that if I were to draw this up on my syringe, you would easily be able to see that my dose is going to be relatively small when it comes to the administration of that medication. So what else are we looking for our epi dose? Well, we need to make sure that we have our dosing cards available and that our IM injection overview is completed. First, we're going to go ahead and prepare the injection site. This includes exposing the extremity, locating our direct site, and then disinfecting it with the use of an alcohol prep pad. From there, we're going to administer our medication. This includes administering the injection at a 90-degree angle to the skin. Once the skin has been punctured, we're going to draw back on the syringe to see for the presence of blood. It's important to note that if we notice a presence of blood, that we immediately withdraw the needle, discard the medication, redraw up, and administer again in a different location to avoid a blood vessel. Last, we're going to make sure that verify if blood is absent. From there, we will go ahead and administer the medication through intramuscular push. Once that's completed, we'll dispose of our sharps directly into a sharps container as appropriate, and then we're going to reassess our patient for a response after 3 to 5 minutes. When we look at our epi dosing, our adult dose should be 1 milligram per milliliter in the way in which it's supplied in the vial. We're going to be drawing up 0.3 milligrams or 0.3 milliliters to administer intramuscular. This is going to vary from brand, vial-wise, but labeling should be relatively consistent that epi 1 in 1,000 should come in approximately 1 milligram per milliliter, recognizing our adult dose is 0.3 milligrams, and we should be drawing up a total amount of 0.3 milliliters. For pediatric dosing, we must first determine the patient's weight in order to follow the proper order. This includes the patient's weight in kilograms, and we should be utilizing an appropriate weight-based, length base for weight tape. In this case, you can see the use of the Brazil tape or your mimetic tape as well would work. From there, we can use the patient's age along with our mimetic cards to determine the proper route and dose. Remember, never estimate a pediatric patient's weight. It's extremely important to measure with our weight-based tape measure. For our epi dosing for pediatric, if the child weighs less than 10 kilograms or approximately 20 pounds, we should be contacting medical control prior to the administration if possible. If the child weighs between 10 to 30 kilograms or approximately 60 pounds, we should be administering 0.15 milligrams or 0.15 milliliters intramuscular. If a child weighs over 30 kilograms, we should be utilizing our adult dose of 0.3 milligrams or 0.3 milliliters intramuscular. With our pediatric dosing, again, if the child weighs between 10 to 30 kilograms or approximately 60 pounds, you can see that on my syringe, I'd be drawing up 0.15 milliliters or 1.5 according to the chart here. Again, this is if they're going to be approximately 10 to 30 kilograms. If the pediatric dose, or our child I should say, weighs over 30 kilograms, then we should be utilizing our adult dose of 0.3 milligrams or 0.3 milliliters for intramuscular injection. Now it's important to recognize post-medical control. Contact medical control for any additional IM epinephrine that may be needed for administration. It is okay to redose, but it's important to phone our friend and get permission from the medical control authority or the online medical director. Medication administration errors occur too often. We know that medication errors are often preventable, and medication errors is the third leading cause of death in the United States. Oftentimes we see errors in pediatric and adult dosing because we estimate a patient's weight. Remember, it's critical not to estimate, but to measure our patient's weight and then utilize our reference cards, our MyMedic cards, to ensure the proper dose. We must discuss our 5 rights of medication administration. These include the right patient, the right medication, the right dose and concentration, right route, and right documentation. Let's take a look at each one of these individually. First is the right patient. We must be recognizing that the patient will be suffering from anaphylaxis or severe respiratory distress secondary to asthma or COPD. All of those are critical. Our second right is the right medication. We should be using epinephrine, 1 milligram and 1 milliliter. It's important to make sure that we have that right medication and that we visually check that. It's important also to try to do a cross-check where you have your partner or a secondary provider on scene visualize the medication to ensure that we're actually providing the right medication. Oftentimes, medications in vials can look very similar, and we want to try to avoid any medical errors because of grabbing the wrong drug. A cross-check with visualization from a secondary partner will help prevent that. In this case, our epinephrine is 1 and 1,000, or in this case referring to 1 milligram per 1 milliliter. Right dose and right concentration. For an adult, we should be administering 0.3 milliliters for those weighing greater than 60 pounds. If we're dealing with a pediatric patient weighing less than 60 pounds, we should be administering 0.15 milliliters or 0.15 milligrams. It's important to know the right dose and the right concentration of the medication that we're administering. We also should be looking at the right route. This should be the vastus lateralis that we're administering it, or the lateral side of our thigh, the same location in which we would use an EpiPen for IM injection of epi. In this case, it's important to find that right location to make sure that the medication is absorbed in the right tissue and can end up having a systemic effect for our patient. The last right we have is the right documentation. It's important to know that this includes the indication of when we should be utilizing it, oftentimes associated with the proper protocol, our right dosing, our right route, and watching for our patient's response to make sure that we're seeing an adequate response. And per protocol, we actually have 6 rights of medication administration, which also include the right time. Right time is going to be based on the specific situation for dosing. When it comes to medication administration injection site, again, we're going to be using our vastus lateralis. This is going to be the lateral thigh. This is the preferred site for IM injection, and predominantly because of its rapid absorption because of the tissue and size of the muscle. From here, we should be able to locate the injection site as shown here in the picture, identifying the lateral aspect, and then shooting for mid-thigh. When it comes to the injection site, it's important that we clean the injection site with an alcohol prep pad. When we're cleaning, we're going to start with our alcohol prep pad in the center, and we're going to slowly work ourselves in a circle, moving outwards, pulling germs away from the center of our injection site to maintain a clean and sterile environment. When it comes to medication administration, we must first prepare the medication. This includes drawing up the epinephrine from a vial into a syringe. We need to make sure first that we have our prepared supplies. This includes a 1-inch 25-gauge needle, a 1 milliliter syringe, our alcohol prep pad, a vial containing 1 milligram of 1 milligram per milliliter of epinephrine, and we should also be referencing our B's dosing cards. From here, we're going to go ahead and pop the top off of our vial. From there, we're going to clean using an alcohol prep pad the top of the vial in order to ensure that it is sterile. From there, we're going to attach our 25-gauge 1-inch needle to our 1 milliliter syringe using sterile technique. We'll discuss this further in our skills video. From there, we're going to draw back the appropriate doses. In this case, we're going to be drawing up air. Once we've drawn up air to our appropriate dose, for an adult, we'd be dealing with 0.3 milligrams, and for a pediatric patient, 0.15 milligrams. Again, it's because it's a 1-to-1 concentration. the amount of milligrams you would draw up will directly equate to the amount of milliliters. So in this case, if we're drawing up 0.3 milligrams, we'd be drawing up 0.3 milliliters. From here, we're going to go ahead and take our vial and our air from our syringe, place our needle into the vial, and then go ahead and inject the air. Here you'll hold the vial with one hand, puncture the vial with the needle, flip the vial upside down, and then we're going to be pushing the plunger into the vial to put the air into the vial. This is important so that we pressurize the vial, so that way the medication will be able to travel back easily into our syringe. From here, we're going to draw up the appropriate dosage and then make sure that the tip of the needle is at the very top of the vial as you draw. In this case, we're talking about the vial, making sure the needle is just here located at the tip or the top of the vial. This will be the bottom since it's inverted. Once from there, I'm going to go ahead and remove the needle from the vial. I'm going to tap repetitively onto the syringe to be able to release any air bubbles, and I will then need to inject those out. From here, I need to stop. I need to make sure that I have the proper dose, and this includes confirming with our partner and then ensuring that we have the correct dose. So stop and double check. Confirm the correct dose and verify visually with your partner prior to administering the medication. You'll also find that for intramuscular injection, we should squeeze the muscle to increase the size and depth of the site. This is different than pinching or separating the skin and muscle. We want to pinch to keep the skin tight and taut and make sure that the muscle is pulled up. If an individual has a significant amount of fatty tissue or adipose tissue, you may want to try stretching the skin taut and pressing down to press down the fat tissue to be able to make sure you hit the muscle when you complete your injection. Once we're going to prepare to our injection, we would make sure that we have proper personal protective equipment on. You can see that's not demonstrated in this video or this photo, but it should be. We're going to go ahead and inform the patient that they will feel a poke. We'll typically provide a count on a count of 3, and then we're going to insert the needle smoothly but quickly directly through the skin at a 90-degree angle, making sure that we bury the needle relatively deep to be able to hit the muscle that we're shooting for. Once that our needle is in, we want to draw back on the syringe to verify that blood is not present. If blood is present, we need to make sure that we go ahead and remove the needle, remove the medication without administering it, dispose of it properly, and then repeat our procedure. Draw up a new medication with a new syringe, a new vial, a new needle, clean our site again, and then perform that injection, and making sure that in this case, if we hit a vessel, a blood vessel, we don't want to administer it directly into the venous system. We want to make sure that we're actually having it slowly absorb to the muscle so we get that prolonged effect. If there's no blood that's present, go ahead and inject the medication in one smooth motion, one smooth bolus. From there, we'll remove the needle and place it directly into a sharps container. It's important to plan ahead so that you know that your sharps container is available before you administer the medication. From there, you'll place a bandage over the injection site. It's also important to make sure that we have proper medication administration documentation. Thorough documentation of medication administration is a must, especially for first responders and basic EMTs. This includes things like patient presentation, epinephrine administration information, and the positive and negative effects seen from the administration of the epi. We also want to pay attention to the patient's signs and symptoms. What indications do we have? What clinical suspicions of anaphylaxis or asthma or bronchospasms are present in our patient? Does the individual have any type of medical alert bracelets? And if so, we should document that. And then do they have a prescription for an EpiPen? All those things will be helpful as we consider our epinephrine injection process. We also want to make sure that, again, we recognize the indications, the correct medication, the correct dose and concentration, the correct route, correct time, and patient response. An example for proper documentation will include at 0-22 hours, epi 1 milligram per milliliter, 0.3 milligrams IM in right lateral thigh. That would be an appropriate way of documenting those procedures. We also want to make sure we recognize any positive or negative effects that can administer to our patient, identifying how did the patient react. Document any changes that you see in the patient's condition, and make sure that you record vital signs before and after the administration. And most importantly, remember, if you didn't document it, you didn't do it. remember your 5 routes, and the results of your medication administration. Now, there's always a possibility for a needle stick when you're dealing with any type of needle or intramuscular or subcutaneous injection. In the case of an exposure or a needle stick, immediately wash the affected area with soap and water for a good period of time. Make sure that you also follow your agency's protocol for specific infectious control disease. This oftentimes will involve making sure that you get a follow-up seen by occupational health or other procedures to make sure that you are safe for any type of bloodborne pathogen exposure. Now let's discuss what's going to be included in the CCMCA EPI kit. This includes epinephrine, again in a 1-to-1 concentration, 1 milligram per milliliter. You're going to find 1 milligram per milliliter vial, and you'll have 1 of those. You'll see a luer lock syringe. This is a 1 cc syringe, and you'll have 2 of those in your kit. You'll also have an intramuscular injection needle. This is a 1-inch 25 gauge needle, and you'll have 2 of those. You'll also have an alcohol prep, several of those for single use, and then your B's dosing cards as well. You can reference a YouTube video in order to be able to download the specific skill video or to be able to play that for training as well too. That information can be found on our website at www.kellogg.edu/CCMCA. When we look at operations for the CCMCA EPI kit, we must recognize that participating MFR units will carry an EPI kit. It is to be stored in a secure cabinet or compartment, an area that will have climate control storage to prevent excessive heat or cold, and it must be free from direct sunlight. Our process for exchange will be used with exchange through an ALS unit. They should inspect the expiration dates within the vehicle checklist, and if it's expiring within 15 days or less, there should be an exchange prior to expiration with an ALS unit. The ALS units for Calhoun County will go ahead and they will have specific boxes that they will be able to swap out with you directly after the administration of that medication. I hope that this training was helpful. I know it builds upon the skills that you have as a first responder and a basic EMT with the use of auto-injector epi, but in this case, it will allow for us to be able to keep the costs down and to provide more services to our community. If you have questions, feel free to reach out to us. You can reach us out at ccmca@kellogg.edu, or you can reach out directly to myself at imusc@kellogg.edu, or my phone number to my office, which is 269-565-2652. Thanks, and have a great day.